excited to introduce our next presenter. Dr. Collin McClelland is a board-certified ophthalmologist with advanced fellowship training in neuro-ophthalmology and adult strabismus surgery at Northwest Eye Clinic. He cares for patients with complex vision concerns that involve both the visual system and the nervous system. He helps identify the cause of difficult symptoms and creates a clear, personalized treatment plan for his patients. His presentation today is Developments in Adult Strabismus, Pathogenesis, and Surgical Management. Thank you, Dr. McClelland.
All right. Thank you so much for the opportunity to be here with you guys today, and what a beautiful venue. This is exciting. So hopefully I can keep you guys excited about adult strabismus. For some people it's exciting, for others it's sheer terror, right? I have no relevant financial disclosures. So we're going to have a very sort of focused overview of adult strabismus, focusing mostly on divergence insufficiency esotropia, which you might have heard now goes by the term sagging eye syndrome. And I'm going to explain some of the background of how we've further come to understand that disease. And then we'll talk a little bit about adjustable suture technique as a evolving trend in adult strabismus surgery and the benefits and the cons. So let's start with an 85-year-old lady who comes in with 5 years of intermittent binocular diplopia. Images are horizontal to one another. It occurs in all gaze directions, only occurs at distance. She says when she's reading a book, when she's watching TV, 5 feet away, she doesn't get diplopia. Past medical history seems unrelated, high blood pressure, well controlled. Here's her 9-gaze motility series. So the first thing that strikes you is just the ptosis, right? The bilateral ptosis, and she's got that deep superior sulcus that we commonly see with levator dehiscence. And then if we look at her motility, it looks relatively full. Maybe there's a little bit of upgaze deficit, and then maybe there's a little bit of abduction deficit to both sides, maybe. And then on alternate cover testing, we see that there's a nice comitant, meaning the same in all gaze directions, esotropia, right? But then at near, she's got a 2-prism diopter exophoria. So this is a divergence insufficiency pattern esotropia. What is this? What's the diagnosis? Could this be bilateral 6-nerve palsies? Well, we do know if you have symmetric 6-nerve palsies and they're mild, then it could give you a comitant esotropia. So that's possible. We didn't really see a lot of abduction deficit on the motility, so that would be an argument against this. It's also very slowly progressive, so it's hard to imagine what process would give you a symmetric, slowly progressive 6-nerve palsy. Seems unlikely, but it's possible. Could this be myasthenia gravis? Well, I'll tell you, myasthenia can do anything, literally anything. However, it doesn't usually give you a comitant deviation, and it doesn't give you the story that the patients had binocular diplopia with images horizontal to one another for 5 years. Myasthenia is an evolving disease that is marked by fluctuations in weakness. So they might have an esotropia, and then a month later they have a hypertropia, and then a month later the diplopia goes away and they've got ptosis, right? It's not the same story for 5 years. That doesn't fit.
In Green Bay,
Thyroid eye
Wisconsin,
disease.
you'll find an
So you can
optical
certainly
lab
have an esotropia with thyroid
obsessed
eye
with
disease.
making
It's
two
usually
things:
not comitant, but
the
it
world's
can
best
be.
lenses
So if we
and
had
the
medial
world's
rectus were
happiest humans.
restrictive, and it was
Things
restrictive
that can
the
only be
same
found
both
at Cherry
sides, then
Optical
you could have
Lab,
a
a
comitant
fiercely
esotropia.
independent, family-owned
However,
and
we would
operated
expect a
laboratory
history
since
of
1999.
rejection of the eyes, periocular edema,
At Cherry, our
discomfort,
obsession with making people happy
proptosis,
is
other
more than just a
features of
saying.
the
It's
inflammatory
who we
part
are
of the
and
disease,
how we work.
the orbital inflammatory
With the
part of the
belief
disease
that if
we
you
don't
take
have.
care of people first,
This could certainly
everything
be a
else will
congenital
follow.
decompensated
Making happy humans is a
esophageation,
commitment that
esophoria.
extends beyond the walls of our
Many
lab
times we'll have
and
a
includes
longer
our
history
customers
that,
and
back
their
when I was in
customers.
college and I partied a little too
Our
hard,
happy
drank a little
humans
too much, I'd
mindset
get some double
drives
vision.
everything we do, and
That's
that's
sort of
what
a
truly
story
makes
that would
Cherry
point you
different.
towards this being decompensated long-standing.
Are you ready to see the
And then we
difference?
can have a so-called central esotropia, so brainstem dysfunction or cerebellar dysfunction. Some of the cerebellar atrophies can give us this comitant esotropia Chiari malformation can give us a comitant esotropia. But I'll show you, usually we have other signs and symptoms of ocular motor dysfunction, cerebellar dysfunction. So saccadic smooth pursuit, nystagmus, other things that point us towards it being a central problem or a brain problem rather than an orbital connective tissue problem. So divergence insufficiency esotropia. Historically, the names have been divergence paresis esotropia, divergence paralysis, all based upon this notion that there's dysfunction in the brain of the divergence center. Well, that's a flawed theory we'll get to in a second. And then more recently, age-related distance esotropia is a really nice descriptive term. These are all synonyms that are used. It's a really nice descriptive term of what we see. Patient's got double vision at distance, and it's slowly getting worse. And then sagging eye is perhaps the best name in terms of the underlying pathogenesis of the disease. So this is an esotropia that decreases at near, symptomatic at distance only. I'll tell you, over years, when it gets to be severe, patients can become symptomatic at near, but the story is it started when I was driving or I was watching the symphony, and then the distance at which the esotropia, at which the diplopia occurs has slowly become closer and closer over years. Generally, it's comitant. There are exceptions. There are cases where the esodiviation is larger in lateral gaze, and so that sometimes can make it look like a sixth nerve palsy. Key is its gradual onset and slow progression. Now, diplopia is always acute onset in the sense, right? Because you either have double vision or you don't. But the reality is many of these patients can't really remember the date that they started having double vision. They just say, yeah, occasionally, if I was looking at something really far away, I'd get some double, and then it just became more and more prominent over years. So that's the story you get. It's neurologically isolated. There's no nystagmus, there's normal saccades, there's full motility with the asterisk that sometimes we can see a mild abduction deficit with sagging eye. So when we look at all strabismus types, retrospective study found that divergence insufficiency esotropia represents roughly 11% of acquired adult strabismus, and that was actually the #1 cause. The interesting thing is my sense is that now in my practice, it represents more than 11%. It's extremely common. Every day I see divergence insufficiency esotropia. The mechanism, we started to talk about this. So historically, there was a theory that maybe this was bilateral sixth nerve palsies in all patients. Maybe they had elevated ICP. Well, the reality is patients generally don't have symptoms of high ICP. They don't have papilledema. They don't have a lesion that would explain sixth nerve palsies on the MRI. And most of them have full motility or mild abduction deficits. So that theory didn't pan out. And then there was a long-standing theory proposed by neurologists that there's a failure of the supranuclear divergence center. The problem here is that the vast majority of these patients don't have any CNS pathology. And in those cases where there is CNS pathology, there's no localization. There really doesn't seem to be a divergence center. And in fact, when they looked at this more closely, 25 plus years ago, they looked at 15 patients who did have CNS disease, and they found that there was no localized common location. So some of these patients had clival pathology, some of them had Wernicke's, some of them had Parkinson's disease. And the conclusion after looking at this was that very likely the CNS disease in most of these cases was unrelated to the divergence insufficiency esotropia, a red herring in a sense. People are allowed to have multiple diseases, right? What's interesting is that Joe Deemer, who's a pediatric ophthalmologist, brilliant guy at UCLA, for many years it's been known that patients with moderate or high myopia can develop a progressive turning in of the eyes that was long understood to be a connective tissue problem of the orbit. We called it heavy eye. This has been written about for many, many, many years. Well, Joe Deemer noticed that we saw the same trend in patients who were older who didn't have moderate or high myopia. And so he wrote up this case series of 3 patients, used high-resolution MRI with surface coils to really look at the structures within the orbit. And what he showed was that there was a stretching out of the LR-SR band, which is this connective tissue. The arrows are showing you the LR-SR band. It's the connective tissue that connects the superior rectus down to the lateral rectus. And so in these patients that he was reporting with a divergence insufficiency esotropia of gradual onset, that LR-SR band was stretching out. And then they actually looked at cadaver studies, which showed very similar findings in patients who were younger as opposed to older. That SR band, which starts out as sort of taut, becomes stretched out over years in the 93-year-old. Okay, well, that was a case series of 3 patients. So then he looks a few years later prospectively and scans a bunch of these patients with divergence insufficiency esotropia, compares them to normal controls. And what he found was that, okay, if you look at controls who are over the age of 70, that we can see that the location of the lateral rectus as compared to the center of the globe, that lateral rectus had fallen 2 millimeters as
in Green Bay,
compared to
Wisconsin,
patients
you'll
who
find
were
an
less than
optical lab
70.
obsessed
These are all
with
normal
making
patients
2
without
things:
diplopia, by the way.
the world's best lenses
The patients who are
and
less than
the
70,
world's happiest
basically,
humans.
the LR is right
Things that
at
can
the
only be
center
found
point
at
of the
Cherry
globe.
Optical Lab, a fiercely
And then when we look at
independent,
patients who had
family-owned and operated
divergence
laboratory
precis
since
esotropia,
1999.
both lateral rectus had
At Cherry,
fallen down
our obsession with
approximately
making
6
people happy
millimeters,
is
which
more
when you
than just a
compare to
saying.
the age-matched
It's who take care of people
it was
first.
pretty clear
Commitment that
of the
extends
falling of the
beyond the
lateral
walls of our
rectus. It
lab and
created
includes our
a
customers
functional
and
bilateral
their
lateral
customers.
rectus palsy.
Our
And
happy
then what's
humans
interesting also
mindset
is that
drives
in
everything we
patients who had a
do,
vertical
and that's what
deviation,
truly makes Cherry
cyclovertical
different.
strabismus, a small hyper,
Are you
small
ready to
hypo,
see the difference?
that the hypotropic eye showed that the lateral rectus had fallen more compared to the other side, which makes complete sense, right? As the lateral rectus falls down, it loses its force vectors as an abductor, and it starts to depress the globe. So the hypotropic eye is getting depressed more than the hypertropic eye. So interestingly, later studies have shown that when your LR sags, you're also more likely to have sagging of the eyelid. And so many of these patients have that classic deep sulcus appearance, that sunken appearance, and the levator age-related dehiscence where that levator stretches out. So again, to recap, sagging eye syndrome or divergence precis esotropia, when it comes on gradually in an elderly patient, this is neurologically isolated, and it occurs due to symmetric sagging of the lateral rectus muscles. The lateral rectus muscles fall down, their force vectors change from a pure abductor, now they lose some of their abducting forces, and the eyes turn in. And then we know that if we have asymmetric sagging of the lateral rectus, if one of the LR-SR bands sags more than the other, then we can get a small angle cyclovertical strabismus. Okay, so are all cases of divergence insufficiency related to sagging eye and orbital connective tissue problems? No, they're not. And this study looked at a bunch of patients with divergence insufficiency esotropia and found that approximately 15% are due to a neurologic or a secondary cause. So let's see some examples here, because this is something you'll want to figure out when you're seeing a patient. All right, so this patient came in with, again, the same story. I'm having double vision at distance. Images are side by side, but then her exam shows a very interesting finding. So here she is in primary gaze. When she looks in lateral gaze, we can see this slow upshoot and a fast beat down, right? So nystagmus is named by the fast beat. This is downbeat nystagmus. It is very commonly worse in lateral gaze. That's very characteristic. So this patient had a workup for acquired causes of cerebellar ataxia, essentially, which are the same causes that can lead to downbeat nystagmus. And nothing came back in terms of an etiology. So this patient had idiopathic cerebellar degeneration, which is the most common cause for downbeat nystagmus. and associated with that was a divergence paresis esotropia. So among those 44 patients that had secondary or neurologic causes of their divergence insufficiency esotropia, many of them had nystagmus. Some of them were downbeat, but gaze-evoked nystagmus should be a red flag as well. It's important to note that cerebellar disease, as we talked about before, whether that be some form of cerebellar degeneration or whether that be Chiari malformation, where the cerebellum is getting herniated down through the foramen magnum and squished, we can see this divergence insufficiency esotropia. But we also want to look for other features that indicate cerebellar dysfunction of ocular motor control. So hypermetric saccades, right? When you have the patient, you hold up two targets, have the patient look from one target to the other, you'll see that the eyes will shoot past the target and come back. Okay, so their eyes are shooting past the target and coming back. That's a hypermetric saccade. That's a red flag for cerebellar disease. Square wave jerks, I'll show you an example in a minute. That's a break-in fixation. Basically, the eyes jump off of the target and then they jump back. And they're called square wave jerks because of the tracing. If you have ocular tracing, you'll see that the eye moves off, it freezes and moves back, and so that tracing looks like a square wave. There's gaze-evoked nystagmus, which essentially is when the patient looks off to the side. We have a sustained beating of the eye in that direction. And then saccadic smooth pursuit. When you're checking motility, you have to go slow, right? But if you go slow, patients with saccadic smooth pursuit will ratchet across instead of a nice smooth movement across. Just keep in mind, if you do one of these, which our residents do all the time, right, then that's too fast for the smooth pursuit system, and then patients will have a normal physiologic saccade, right? So you have to check smooth pursuit nice and slowly. All right, so this is a patient who actually has progressive supranuclear palsy. She kind of has that Parkinsonian stare. And so what I'm showing you, if you look at her eyes, are square wave jerks. So it's a break-in fixation. The eyes jump off the target and they come back. Square wave jerks are very common with cerebellar disease. They're common with Parkinsonism. They're very common with cousins of Parkinson's disease, such as progressive supranuclear palsy. I didn't show you this patient's motility, but she had a lot of difficulty with up gaze and down gaze, so her vertical saccades were significantly impaired. Okay, so things to look for as a secondary cause of divergence insufficiency esotropia. Of course, acute onset, sudden onset, that's always a red flag. You can have sagging eye with sudden onset, but it's just not as common. So that prompts a workup, including neuroimaging. If you see a significant motility deficit, like a -2 abduction deficit, or roughly 50% of normal function of abduction, that's a little bit more than we normally see, and you probably should work that patient up for a 6th nerve palsy. Of course, if there's associated papilledema, then that's not your run-of-the-mill sagging eye. If they're pretty young, now if they're young with high myopia, okay, we have an explanation. But if they're young and they're not highly myopic, well then I think, again, you have to think about other causes beyond sagging eye. So if you have a patient who's got slow progression of distance esotropia, it's comitant, the motility is pretty full, you don't have to work that patient up. I think that's a patient that you can offer prisms to, and we'll talk about prisms in just a minute. They'll be very happy. And there's not a workup necessary. No one's ever going to fault you if you are not sure and you do a workup, then I think it's reasonable to do. But those patients can be observed. If you see the red flags that we talked about, then I would get an MRI brain in orbits with and without contrast. By the way, we see these findings of sagging of the LR on an MRI, but you can't really be certain or diagnose sagging eye based upon the MRI. We're not getting the MRI to rule in sagging eye syndrome. We're getting it to rule out all the other potential causes. And then we would think about some of these various causes that we talked about, and we kind of went through these already. So, treatment for sagging eye. The vast majority of these patients do really well in prisms. They're very happy in prisms. Of course, we have strabismus surgery, and there's two main indications for strabismus surgery. One is if their glass is intolerant, and part of this is because of the common era that we have now that everyone wants to be glasses free, right? They get really outstanding, I hear some chuckling in the audience, right? You're familiar with these patients. They have an outstanding cataract surgery. They're seeing crystal clear at distance, but now they've got a small angle esotropia and they're diplopic and they don't want to wear glasses. So historically, we've offered surgery for patients that are maybe 6 prism diopters or more of ET. However, we can push the envelope on that. You can certainly do surgery for smaller deviations. There's a few things that I keep in mind. Number one is, what are their convergence amplitudes? So for instance, if I overcorrect them, how well do they tolerate that? And if they have really robust convergence amplitudes, so I can make them 20 prism diopters exophoric and they can fuse, that makes me feel more confident, hey, let's go for this because I can overcorrect them, I'll leave them exophoric, and then they'll have probably years of a buffer as the eyes will slowly drift back in because this is a progressive condition. They'll have years of single vision. If the patient has poor convergence amplitudes and poor divergence amplitudes, then that's a patient that I might fix, and then within 6 months, they're going to be diplopic again and need prisms. So that helps me to decide whether I would offer them small angle strabismus surgery or not. If they're prism intolerant, so let's say, you treat a patient for years with prisms and they're doing really well, but we're getting up now to the 12 or 14 prism diopter total mark, and that's usually, in my mind, when most patients become intolerant. They start describing the glasses as being heavy. They're getting kind of this fishbowl prismatic appearance to their vision. Then I think it's very, very reasonable, whether they have good fusional amplitudes or not, meaning even if they have a really small window for single vision, if we get them close to ortho, they'll be very happy to reduce the amount of prism in their glasses. Let's talk a little bit about some of the innovations in adult strabismus surgery. So let's talk about this in the context of a case, and these are real glasses I took a picture of because I was like, holy cow, I didn't even know they could make them that thick, right? 61-year-old coming in, been wearing prism glasses since age 34. Prisms have been slowly increasing over time. The prior prism glasses had 11 base out from 2 years before, and now we're at 18 base out, which I snapped a picture of. I feel like these patients roll in out of the Dakotas all the time. So wearing a -6 spherical equivalent, so there is an element of myopia, which throws in this element of, are we dealing with perhaps heavy eye? However, the prism glasses started at age 34, so is this decompensated congenital deviation? Maybe it's both. Maybe it's decompensated congenital plus heavy eye / sagging eye, which there's really on a spectrum. Already underwent an MRI, it was unremarkable. So here's the sensory motor examination. So in primary, we've got a 20 prism diopter esotropia. It's the same in right gaze, and in left gaze, it's a 25 prism diopter. So a little bit of incompetence. This doesn't concern me. It's quite common that we see a little bit of incompetence with divergence insufficiency. Plus, the patient has already undergone an MRI, so I'm not worried about some occult left 6 nerve palsy from a lesion like a meningioma or something like that. Fusional amplitudes, not very good, right? So the patient fuses 16 to 20 base out. So if I overcorrect her by even 5 prism diopters, she's not able to compensate that. There's a really narrow window for success here. So again, is this a decompensated congenital esophoria? Arguing that is that she started wearing prism glasses at age 30, well before we would expect someone with sagging eye to present. However, she's also a moderate myope, and so there's a possibility that she has a couple things at play, and it gets impossible to know at this point. I really don't know. I'm showing you just an example of what an MRI from a heavy eye patient looks like. So we can first see that the eyeball is quite large, filling up most of the orbit. And up here we have the superior rectus, which is kind of nasally displaced, and then the lateral rectus down here. And then the entire globe is sort of prolapsed supratemporally. So this is a classic picture for heavy eye syndrome. I went and I looked at her MRI, and she had element of that, but again, I can't look at that and know for sure if that's the underlying cause versus a congenital decompensation of an esotropia. So you say, okay, well, this is getting esoteric. Why does it even matter? Just fix it already. Well, it matters because the dosing on fixing it is dependent upon the underlying etiology. Okay, so what am I talking about? Well, if this is decompensated congenital esophoria, then we would use our Parkes formulas for surgery that say we should recess the medial rectus about 3.5 to target, in her case, 20 prism diopters. Okay, what if it's sagging eye, heavy eye spectrum? Well, surgeons who operate on these patients regularly know you have to basically double the angle that you're operating for. So you would want to recess the medial rectus 5 millimeters to get the effect you're looking for, because the problem is the lateral rectus. The problem's not the medial rectus. So you're not actually, if you're recessing the medials, you're not addressing the underlying problem. So that's the issue, is that if we're going to operate on the medials, we got to know which of the two it is if we're going to use a fixed suture technique, meaning not adjustable. Also, we could do something else. There's a surgery called the loop myopexy, where we suture the lateral rectus to the superior rectus. It's a pretty big surgery and it's a little bit unpredictable, so I don't do that very often unless it's really bad heavy eye. And then lateral rectus resections, that's my go-to in general in most cases now, because I found it's just more predictable. However, it does result sometimes in a little bit more pain for patients because you're actually removing a segment of the muscle and more uncomfortable. So here we are with our patient. There's an element of sagging over here. However, it's not really clear whether this is heavy eye or not. So my plan was to use an adjustable suture technique. On the right medial rectus, I use fixed suture, and on the left, I have an adjustable suture. So the reality is, by having that left on an adjustable suture, it allows me to target anywhere from 12.5 to 40 prism diopters of esotropia correction. So I should be able to get whatever I need, whether she's got a decompensated congenital deviation or whether it's heavy eye or whether it's a mix. The adjustable allows me the flexibility to get it right. A little bit about adjustable sutures. So even though I'm presenting this sort of as a novel update, it's been around a long time. First described back in 1975 with the bow tie technique. I like to use the sliding noose. I don't tell patients about the noose. They don't like that. I'm going to tighten the noose, sir. So I call it the N suture when I'm talking to the residents. So this is the sliding noose technique. So we've got the muscle hanging back. So this is a recession. And then right here is the noose. And I have the ability postoperatively to slide that this direction, which would increase the recession, or I can slide it the other direction and advance the muscle and decrease the recession. What are the pros of adjustable suture? Well, it allows you tailored surgical dosing, just as I presented to you. The Parkes criteria that we use for operating on patients are the same for a 2-year-old with congenital esotropia and a 90-year-old with sagging eye, which of course the pathogenesis is going to be different between those two. What are the odds that the formulas would be the same? They're not. So that's the problem with our formulas. They're very generic. Adjustable is really helpful for those cases like this one where we have a small window for success. If the patient's goal is to be prism-free, then the adjustable allows us that sort of precision. It's also really helpful for restrictive strabismus like thyroid eye disease, where the dosing is very, very unpredictable. And then paretic strabismus similarly gives us very unpredictable dosing. The cons, people will argue that the short-term outcome, meaning what you have right after you adjust, doesn't necessarily predict the long-term outcome. And that is true. Depending on what the disease is, that's where the art of strabismus surgery comes in. So there's cases where I know I'm going to need to overcorrect this patient. I'm going to adjust them and leave them overcorrected with the adjustment because I predict that they're going to drift back in, for instance, over time. The large noose can expose and be uncomfortable. It's generally not a serious problem, but it is a little bit more uncomfortable in the postoperative period as patients are healing. It's time intensive for the surgeon. It adds an element of, 15 minutes to an hour or so. And then some surgeons have called it barbaric. How can you possibly have an awake patient and you're moving their muscles around. It's just terrible. I'll never do it. And I think that assuming you choose your patients carefully, that's not true. So in my mind, there's some relative contraindications. If the adjustable suture is not going to benefit them, meaning I'm dealing with something that's a highly predictable outcome, then I don't feel like I'm not going to do the adjustment. Why would I do it? It's just putting the patient through potentially an uncomfortable procedure and taking extra time. I also watch for the adult teddy bear sign. I've had 2 patients who showed up for surgery with their stuffed animal, and both of those adjustments went terribly in the sense that just extremely uncomfortable. And joking aside, my point is that I look very carefully during the pre-op evaluation about whether I think that they will tolerate the adjustment or not. Generally, it's actually not about the pain, it's about the anxiety of someone working on their eyes while they're awake. So those patients who squeeze when you try to do their indirect exam, and they're squeezing like crazy and they won't let you look or they won't let you put drops in, those patients are not good for adjustable suture. Patients with dementia, I have found that they often wake up really poorly from anesthesia. They're confused and sometimes very agitated, and so I tend to not do adjustable suture unless I feel like they really, really, really need it. And then patients who've had prior adverse reactions to anesthesia, so if they wake up highly nauseous every time and they're throwing up like crazy, that's really not someone that you want to be doing an adjustable suture on. Also, patients who are chronic pain sufferers, who are on chronic narcotics, unfortunately, I found that their pain after surgery is just way out of proportion to the expected. And so many times I'll have a candid conversation with them, like, listen, I think it's probably better if you don't have to cooperate with an adjustment because you're likely to be in quite a bit of pain. So is it evidence-based? And so they've tried to look at this. They tried to look at randomized control trials prospectively comparing adjustable to non-adjustable sutures. And I just laugh because they couldn't find a single study that met that criteria. So this was intended to be a meta-analysis. And the take-home message is there are no studies to analyze. Retrospectively, there is some evidence. This was one of the larger studies that compared adjustable to non-adjustable suture. They found lower reoperation rates, higher contentment for the cases that are you're looking to achieve cosmesis as opposed to double vision, and also higher rates of no diplopia in primary gaze and reading. So this study at least found that there was a benefit to using adjustable suture. The reality is there's been other studies that have not found a benefit, and I think it's all about patient selection. I do believe that in the right patients, it's very helpful, but you don't need to do it for everybody because it's not useful for everybody. So now I'm going to take you back to my patient who is the -6 myope. She's just woke up after surgery, and we're getting ready to do the adjustment. Here's what she has to say before we do the adjustment.
So she is now woken up and we're about to do an adjustment. What do you notice already?
There's no double vision. I can see people way down the hall. It's just wonderful.
You notice a big difference?
A huge difference.
So the old prism glasses were kind of distorting your vision some?
Yes, a lot more than I expected. I knew it was distorting it some, but this is just unreal. I can't get over how clear things are.
All right. Promise this isn't an infomercial. I didn't pay her to do this. But I did choose my videos carefully. So we've got the adjustment. You might be thinking, okay, she's seeing single. You're not going to adjust. You're just going to tie off the sutures. It's done. She's happy, clearly, right? Well, so in the PACU, we do alternate cover testing. She's wearing her prism-free glasses. And I find that there's a 4 prism diopter ESO deviation. So she's fusing it right now, but do you remember she only fused 16 to 20 preoperatively? 16 to 20 base out correction. So she has a very narrow window for fusion, and she's already at 4 prism diopters esotropia right now. I don't want to leave her there because she's going to go home and she's going to be diplopic again pretty quickly. So here's the adjustment that we do. I'm going to recess that left medial rectus a little bit more.
So here we can see the pole suture. Here's the end
So
suture.
the top left is the
Slides
pole
along
suture.
the pole suture.
The sliding end suture is the white
Here's our
suture.
traction suture.
This is my traction suture that allows me
And
to hold
over
onto
here
the
is our
globe.
conjunctival suture.
And then the suture you can't see there is the
Just
conjunctival
a second,
suture.
you'll feel some tugging, okay?
Okay.
So I'm about to
three.
move the noose.
Okay. Now over to the right.
That was
Pull to
about
the
2
right,
millimeters.
Pull to the right as far as you can.
Now I'm asking
Good.
her to look
Okay.
to the right as I hold the
And
globe, which
back to the
allows
left.
that muscle to fall
You
back.
can see that's pulled
I move the
down
noose
now.
and then I
Okay.
allow that muscle to slide over. On the alternate cover testing, she's now ortho
We'll trim one short.
after recessing the left medial 2 millimeters more. I'm just tying off the sutures. I don't send them home with sutures hanging out of the eye. And we're just trimming everything up, closing the conjunctiva, and cutting out the traction suture. Okay, so question of barbaric. And this is my counterpoint to people who say it's barbaric. Let's ask her if it was barbaric.
It went so easy.
The adjustment went easy.
Yes. When you said that it would, maybe be uncomfortable, you could feel just a very slight tug. That was it. It was not painful. It was so easy and so quick.
So she did not have a teddy bear with her that day. But choosing the patient carefully is super important. I could tell that she was going to do great with it. It's all about profiling. My young men oftentimes do not do well, right? So I try to figure out, I've gotten pretty good through the years of figuring out who's going to do well with it or not. So here she is, post-op month 4, which basically is our long-term outcome visit. She's doing great. Ortho, happy. So looking back, if I had used fixed suture technique and I had recessed the medials and I had done it thinking that it was a decompensated congenital deviation, I would have massively undercorrected her, right? Because I recessed one medial 4 and the other one 6. And I got the result we needed. But if we had gone with 3.5 on both, we would have undercorrected her. In conclusion, divergence insufficiency, esotropia, divergence paresis esotropia, really is a connective tissue disorder, which is best understood now by the term sagging eye syndrome. Extremely common. Everyone in this room has seen patients with it, and you're going to see a lot more patients in the future. Roughly 15% of patients will have associated neurologic disease, right? There's features that highlight that. We went through the red flags, young patients, nystagmus, psychotic smooth pursuit, things like that that tell you you're not dealing with age-related orbital connective tissue degeneration. Adjustable suture is a low-risk modification of strabismus surgery that can improve outcomes, in my opinion, in select patients. So happy to offer neuro-op help in the future. I'm now with Northwest Eye. I was at University of Minnesota for years. If you have a referral, please put it in on the website. Everything runs through the website. If it's something urgent, still put it through on the website, mark it as urgent, and then give us a call, send us an email, and we'll work to try to get those patients in. In the event that I can't get them in an expedited fashion, I will let you know that quickly. And then we have a really big adult strabismus team at Northwest Eye. All 5 of us do adult strabismus surgery, and so hopefully we can take care of any patient care needs that you have. Our goal is always communication. You should be getting a letter back from us. And my goal is always to get patients back to their primary eye care provider. I'm not trying to take patients from you. I want to get them back to you. This is my family. I'd be happy to take any questions at this point.